Good morning, and today our topic of discussion is hypokalemia and hyperkalemia, which are very important in diagnostics, lab diagnostics. And as I told you that whenever it is about hypo or hyperkalemia, always think about the heart in this case, whereas in hypo and hypernatremia, always think about the uh, brain. Now, a few words about potassium hemostasis. As we know that the normal value of potassium in the blood is between 3.5 to 5 millimole per liter, or you can say milliequivalent per liter. And we say hypokalemia when the level is less than 3.5, and hyperkalemia when the level is more than 5 milliequivalent per liter. Now, a few things to understand over here is potassium is basically the ion of, like, they are in the cells. So you can say like the cells are basically the packets of potassium. And whenever, for example, the cells will burst or they will be injured too much in the body, for example, in muscle damage or like huge muscle damage, like the cells will be damaged and the potassiums are going to spill out in the blood, which will lead to hyperkalemia. So you can say like approximately 98% of the potassium um, in the body, or the total potassium in the body, uh, are basically intracellular. They are inside the cell. And what happens like whenever um, intracellular, okay, sorry, intracellular. Okay, yeah, what happens like whenever the potassium will be present in the ECF, which will lead to hyperkalemia, remember, like, it's a life-threatening condition. So hyperkalemia especially is a life-threatening condition, in which, what you can say, we have to remove the potassium from the cell, from the body, from the blood, by different ways. For example, one of the way is called as hemodialysis, um, in which we remove the potassium from the body by the help of filtering the blood. Uh, One very important point which is used when we treat the patients of hyperkalemia is basically remembering this thing like insulin, as well as catecholamines. Uh, um, what they do, like uh, um, they shift the extracellular potassium inside the cell. So what we do, like, for example, if we will give insulin to any patient, any person, so what will happen, like, the insulin is going to move the potassium from the ECF to the ICF, or from the extracellular fluid inside the cells. Okay. uh, and we know, like, the potassiums, they are regulated by the kidney, and whenever there is kidney failure, of course, like, what will happen, like, there will be hyperkalemia. So um, simply, the kidneys play a very important role, and whenever the potassium level in the body is high, it is the kidneys which are going to throw the potassium outside the body, in the urine. um, of course, like, there are many drugs which play a role. There are many things which play a role. For example, um, whenever, like, the tubules are getting more and more, the urine flow, or simply, like, there is thiazide diuretics, they had the effect on the potassium and things like this. Now, aldosterone has a very minor effect on potassium. Like, whenever there is aldosterone is activated, or aldosterone is released in the body, what you can say, it causes aldosterone. Like, if you know, like, what is renin angiotensin aldosterone system, so aldosterone, basically what it does, it is going to retain, or you can say reabsorb, the sodium. okay, and it excrete potassium. Okay, this is very important point, but it have very less effect on the potassium, right? It do excrete the potassium, but it doesn't play any role whenever there is, like you can say, a very minor role whenever there is hyperkalemia in the body. Um, as well as whenever there is metabolic alkalosis, it also increases the potassium secretion. Um, and there are many drugs which also play a role, diuretics as well as penicillin. And for example, penicillin and salicylates, they also increase the tubular flow rate, and they also increases the potassium secretion. Okay, so you can say like bicarbonates, bicarbonates, penicillins, okay, thiazides, and salicylates. They increase potassium secretion. Okay, so like these are all the things which increases the potassium secretion. So first of all, we are going to discuss hypokalemia. Okay, and like the same thing, we are going to discuss the causes of hypokalemia, and once we will discuss them, um, then we will talk about what you can say. Um, Hypokalemia, what is that? Like, of course, when the level of potassium is less than 3.5, we call it as hypokalemia. Now, these are the causes of hypokalemia in this diagram, in this table. We will read about the different causes of hypokalemia. Okay. So now you can see over here, um, whatever, like whenever there is hypokalemia, what is the causes is, it could be due to decreased intake when someone is taking it less in the diet. It could be due to increased losses, or it could be due to transcellular shift. Like the potassium is same in the body, but what happens is like simply more and more potassium will move intracellularly. For example, you can see in metabolic alkalosis, what happened is, like, of course, alkalosis means what? There is less hydrogen ions. So what will happen, like the potassium hydrogen exchange occurs around the cell membrane, and what it will do, it is going to move more and more potassium inside and more uh, hydrogen ions outside the cell. So it will lead to hypokalemia. As well as sometimes when the people, they get insulin, so insulin, as you know, like it stimulates the sodium potassium ATPase pump, and it is going to move more and more potassium inside the cells. As well as catecholamines, which I already explained in the previous slide. Beta 2 agonist theophylline, they also stimulate the sodium potassium ATPase pump. Tocolytic drugs, which are drugs which we give to delay the labor, and for example, uptake into the newly forming cells. For example, when we give vitamin B12 injections in someone who have vitamin B12 deficiency, so more and more cells are formed, and the cells take in more and more potassium, so there could be hypokalemia. Increased losses, of course, it will be through the urine. And see, we can check the spot urine to check like the potassium to the creatinine ratio. So it could be less than 1 or more than 1. So whenever it is less than 1, it means, like, of course, like less potassium is going to lose in the urine. So of course, like it means like the potassium are lost other than urine. So in this case, GIT losses, diarrhea, laxatives, or villus adenoma. And whenever like the spot urine shows potassium to creatinine ratio more than 1, so it means like this person is having renal losses. So whenever there is renal losses, check the blood pressure. So either the person will be normotensive or hypotensive, or either the patient will be hypertensive. So whenever the patient is hypertensive and there is less potassium, this is very interesting condition. So this is the condition, we call it as hyperaldosteronism. As you know that aldosterone is the one which retain the sodium and throw out the potassium. So, by the way, whenever we approach anyone with high blood pressure, what we do, we check their potassium level. So when the potassium is less, so we say that we like it is one of the pointer towards think about hyperaldosteronism, which could be primary, which could be secondary. Primary hyperaldosteronism is also called as Cohen syndrome, whereas secondary hyperaldosteronism could be due to many things like renovascular disease, renin tumor, or non-aldosterone mineralocorticoids like in Cushing syndrome. Whenever the person is hypotensive, okay, we must check their acid-base balance. They, of course, like they could be alkalemic, there could be acidemic, and there could be variable. So acidemic, think about diabetic ketoacidosis or renal tubular acidosis, and alkalosis. It could be due to diuretics. It could be inherited renal tubular disorders like Bartter syndrome or Gentleman syndrome. These are long discussions, of course, and variable like in nausea, vomiting, and angitube. So, like this is how we go whenever like there's someone is having hypokalemia. So this is how we can search the causes. Okay. So depending on, for example, in the history you can find this thing, or the person is taking some drugs, or the like you found like there is more and more GIT losses or more and more renal losses. So or either the patient is having a history of laxative use or diarrhea, or we will check the blood pressure, right? So these are all the causes of hypokalemia. What are the clinical features of hypokalemia? And depending on how much hypokalemic the patient is, the person may be asymptomatic, okay, like without any symptoms. This is the case when the hypokalemia is usually mild, like you can say less than 3.5 but more than 3. Okay, so most of the patients they remain asymptomatic when their level is between 3.3 to 3.5 millimole per liter or milliequivalent per liter, like whatever you like, you can write. But whenever, like, of course, like the person have severe hypokalemia, the person may present with nausea and vomiting, as well as weakness, generalized weakness. Okay, and they can present with muscle cramps, as well as they can present with constipation. Like now, to understand these six guys, you must know the basics. How the neuromuscular junctions and how the muscles they contract and all this stuff. Now, the important thing I want to mention over here about hypokalemia is what? Whenever hypokalemia is severe or there is severe hypokalemia, now these are the patients who can present with serious complications like cardiac arrhythmias, or you can say the rhythm abnormalities. Uh, Very severe type of hypokalemia can also lead to respiratory paralysis or respiratory muscle paralysis. Uh, now, cardiac arrhythmias which occur in response to hypokalemia, there are many factors which play a role in this case. For example, um, like if the person is using some drugs like digoxin, or hypokalemia, if it is coupled with hypomagnesemia, the consequences can be dangerous. And one thing to mention over here is the ECG changes in hypokalemia. And to show you that this is the best, you can say, thing you can understand. Like this is the normal ECG, see P, Q, R, S, and T waves. But whenever like the person have hypokalemia, uh, we found U waves. So remember, see, there is a prominent U wave, right? They have either flattened or inverted, sometimes inverted T waves. So here, see that the T wave is rounded up, but here, see the T wave is flattening or going towards flattening. Okay, it could be inverted as well. Here it is written shallow T wave, right? The SC segment get depressed, there is prolongation of this QT interval, okay, and the person, they can go into sinus bradycardia. In severe type of hypokalemia, there could be widening of QRS complex, okay, and these are the ECG changes we can see in hypokalemia. And that's the reason, like whenever we are suspecting anyone with hypokalemia, we directly go for ECG of the patient, okay. So the U wave, they started appearing, and then they progressed. Like what happened, like like in the start, they started appearing like this, and they become big and big, and like the T wave, they become inverted, okay. So the U wave progresses in this way. They have slightly prolonged PR interval as well, you can see over here, okay. So this is how the patients of hypokalemia present, and how we treat or approach hypokalemia is simply, you can say, treatment and approach to hypokalemia. Okay, so whenever like the patient, they present with this, hypokalemia, the first thing in emergency we do, we obtain a ECG, okay. And of course, like if the person have what you can say a life-threatening type of hypokalemia, what we do, like we quickly go for management or treatment. So we obtain ECG, we see the ECG changes, and most of the time, hypokalemia comes with metabolic alkalosis. I told you why, because in metabolic alkalosis there is less hydrogen ions. So what you can say, the hydrogen ions are going to move outside from the cell, and potassium are going to move inside, because there will be potassium hydrogen exchanges going on. So that's why always rule out transcellular shift, okay. So what you will do, how you will rule out, obtain ABG, just to see like either the patient is having alkalosis or not, okay. So now in this case, of course, like when there is this case, of course, it means like the level of the potassium in the body is fine, but like there is just transcellular shift. Then of course, like what you will do in the history, you will ask for dietary potassium intake, okay, depending on the condition, of course, like, but we have to discuss all the conditions. And one of the things you are going to obtain is spot, you can say, potassium ratio to creatinine, as I told you, just to see either there is GI losses or either there is renal losses. What I'm talking about is this one, okay. This is the best test to see either there is renal losses or either there is GIT losses as well. One of the tests we can do is 24 hours potassium excretion test, okay. Of course, like to look like how in 24 hours how much potassium we can lose. Check the blood pressure, very important, as I told you, primary or secondary hyperaldosteronism, okay. Check, do, like, of course we already talk about that, but do ABGs, okay. And also one more test you can do, like few more tests you can do, you can check the plasma renin levels, okay. You can check the plasma aldosterone levels, okay. You can always check the serum magnesium levels, okay. So see, all these things like make sense because I already told you the causes, right? So all these things make sense. What we are going to check is to the cause, okay. So how we treat hypokalemia is simply, once you have done all those stuff, what you are going to do is to simply whatever, like for example, treat the underlying cause. Of course, when you know that, when you catch the cause, of course you will treat that. So depending now upon the cause, you can treat that, or depending on like how to treat that. For example, if you found uh, that potassium, you can say, deficit in the body is true, like there is no transcellular shift. So of course, in this case, what we have to do, we have to, um, of course, give the patient what is lost. Okay, for example, we will give them oral potassium. Okay, uh, see, it can be given in the form of food, for example, in the form of tablets. Like clinically, the tablets of potassium, they are available. Or you can give like liquid potassium solutions as well. They are available clinically. But of course, like some of the patients, they cannot eat, they cannot take anything per orally, then we give them IV potassium replacement. Okay. Uh, of course, like and one thing, to make sure when we are giving IV potassium replacement, so don't give it, you can say, or avoid, you can say, dextrose uh, solutions. Okay, why? Because when you will give a dextrose solution, what will happen, that in response to glucose in the body, what will happen, that the body is going to release more and more insulin, and the insulin will move more and more potassium inside the cell. So that's why we avoid dextrose solution in this case when we are dealing with hypokalemia. So how much is given? By the way, we can give maximum of 40 millimole per liter via peripheral vein, or maximum 60 millimole per liter via central vein, and never give more than 20 millimole per liter, millimole per hour, okay, in the patients. One of the way is like we can give them potassium sparing diuretics, and when you will study pharmacology, you would know, like there are some diuretics which are potassium sparing, like they throw out the sodium, but like they keep on, like they retain the potassium inside the body. Like the examples are triamytrine or amiloride. Okay, spironolactone is one of the example as well. One of the thing is correct hypomagnesemia. Okay, correct the magnesium level. Very, very, very important thing. So correct this thing. Um, Now, be cautious when you are dealing with hypokalemia. Don't overcorrect it. Don't put the patient in hyperkalemic situation. Okay, that's very important. Especially in the patients who are diabetic, and especially in the patients who are elderly, and especially in the patients who have renal failure. Why? Because the kidneys, they cannot throw out potassium in renal failure. So this is like important, and be cautious when you are dealing with uh, like transcellular shift. Like in that case, of course, if you will provide too much potassium, what can happen is simply the patient can go into hyperkalemia. Okay, other than this, like the next thing which we are going to study is hyperkalemia. Now, when we say that the patient have hyperkalemia, is simply when the potassium level is more than 5 millimole per liter. Now, guys, the causes of hyperkalemia are quite straightforward, and they are, like you can say, simply be called as, you can say, simply, there could be increased up intake. Okay, there could be transcellular shift. Now, see, like the potassium, when it comes out of the cell in the blood, of course, like it's a transcellular shift. There could be decreased excretion, like the body is throwing out less potassium. And one of the thing which is there, it is called as factitious. Factitious means what? Like simply you got a bad or a wrong results of potassium, right? I will talk about this one. And by the way, factitious is the most common cause of hyperkalemia. Okay, so increased intake. So someone who is taking more and more potassium in the form of diet, or in the form of tablets, or simply you overcorrect any one potassium level, like you give too much IV potassium chloride. Okay, So of course, like that will put the patient into hyperkalemia. When it comes to the transcellular shift, guys, where is the potassium located? It is inside the cell. So now remember, whenever the cells are destroyed in the body in a huge quantity, they are going to release more and more potassium in the blood. Same like I told you before, that when the new cells are forming, they are going to uptake more and more potassium. So again, that's a transcellular shift in which the potassium is moving inside the cell. Now in this case, the potassium is moving outside the cell. So for example, when there is a lot of hemolysis is going on, the red blood cells are bursting up, and what will happen? There will be hyperkalemia. For example, when the muscle damage is there, for you can say rhabdomyolysis, myolysis, the muscle cells, in crushing injuries, like someone muscles is crushed under, for example, a tire of the car. So all those muscle cells, they are going to release more and more potassium. Tumor lysis syndrome. In many of the cancers, when there is tumors, malignancies, especially hematological malignancies, when we give them drugs and the tumors are destroyed quickly, so they release a lot of potassium. As well as acidemia, like alkalosis, it causes the shift of potassium inside the cell. Acidosis will do the opposite. Okay, it is going to put the cells potassium outside the cell. And see, all the drugs, uh, like opposite to those drugs, like digitalis, beta blockers, they can all cause transcellular shift. Okay, in this case, the potassium will leave the cell and come in the blood or in the plasma or in the serum. Decreased excretion, guys, remember, renal failure. Whenever the kidneys are not functioning well, simply they will not, body cannot get rid of potassium which is inside. Or when there is hypotension, severe hypotension, of course, when the kidneys are getting less blood, so they cannot put the potassium outside. So this thing, and hyperaldosteronism can cause hypokalemia. So hypoaldosteronism can cause hypokalemia. Okay, factitious is a very interesting thing. What happens, like there is sample hemolysis. What happens is, guys, you take the blood from the patient, and when you transferring that blood in a tube, there is hemolysis going on. The cells are going to burst, and more potassium will be in that sample. Or for example, you are taking the sample from a vein in which you are giving an infusion of potassium. Of course, like not so common, but this one, sample hemolysis, is the most common one. Okay, so this thing is very, very, very important thing. Okay, it is the most common cause of hyperkalemia. Okay, so hypoaldosteronism, like when the aldosterone is decreased, what will happen? Like, of course, like it is going to throw out more and more sodium and retain more and more potassium. Okay. Now, decreased aldosterone levels can be with low renin as well as low aldosterone, or it could be with normal renin with low aldosterone, or it could be aldosterone resistant. For example, when person is getting some potassium sparing diuretics. Okay. Like spironolactone or amiloride or triamterene. I give you the example already for that, right? People who use NSAIDs, or the people who have diabetic nephropathy, what they have is like they have low renin, low aldosterone, as well as increased potassium levels. Okay, so all these things are important. Now, how we approach the patient, or what is the approach in hyperkalemia? As I told you, hyperkalemia is a life-threatening condition, right? So remember, guys, again the same thing: obtain ECG. Obtain ECG. Very, very, very important thing. Now, again, I will show you one very nice type of thing. We are not discussing this one because it's hypokalemia. We will look in this one. See, What are the ECG changes in these hyperkalemia patients? You can quickly see this one. Hyperkalemia. Okay, what happening in hypokalemia? See, T waves inverted or flattened. Opposite will happen in hyperkalemia. Tall, tented, or peak T waves will be there. This is the most important thing to remember. Tall, tented T waves in hyperkalemia. Flattened or inverted T waves in hypokalemia. There are other changes like long PR interval, wide QRS complex, and all this stuff. But remember, tall tented T waves are the thing we are going to get in hyperkalemia. So obtain ECG quickly, see the changes, rule out in this case, which is what is the most common cause? Factitious. Rule out factitious, like either the blood sample was uh, hemolyzed or not. So how you will rule out? Like you can repeat a test. Repeat a test and make sure it should not be hemolyzed. Okay. Hold any potassium infusion if you are giving, or potassium orally or IV, both. Hold both. And look for transcellular shift. Now, how you will look for that? Either the patient is getting any insulin, okay, or either there is any damage, okay, sorry, so either the patient is having hyperglycemia, either there is any damage going on, like all this causes, for transcellular, either there is hemolysis going on, either there is tumor lysis syndrome, or either there is acidemia, right? So look for all these causes. And one of the important thing is to estimate the GFR. Remember, for the decreased secretion causes. Remember, when there is hypotension, there will be decreased GFR, right? So, how we go for the treatment, guys? Very, very, very important topic. This is really important. This is going to help you, or it can come along you again and again in medicine, in clinics, in wards, in real life, right? How we treat hyperkalemia. First of all, remember it's a life-threatening condition, so it's an emergency. You have to deal it on emergency basis, right? There is a mnemonic also to remember, like how to deal with this thing, but leave the mnemonics. It's very easy to remember the thing. So it's an emergency. You must treat it acutely, okay? And we treat that regardless of how the patient, either they have ECG changes or not, okay? So there could be many things. For example, either the level of the potassium is less than 6.5 and normal ECG. Okay. So in this case, of course, it's not that much emergency. So what to do in these cases is simply treat the underlying cause. Okay. Stop or hold potassium orally or IV, whatever you are giving. Okay. And increase the excretion, okay, uh, by urine or by GIT, whatever. The other condition can be 6.5 to 7.0, okay. No ECG changes yet. Just do one thing: add insulin. What insulin will do? Insulin is going to move more and more potassium from the plasma in the cell, from the ECF to ICF. And the third condition is when the level of the potassium is more than 7.0 and or ECG changes are there. Now, our priority in this case is to protect the heart. And how we protect the heart? We give them calcium gluconate. This is the most important step you have to do. Now, what is calcium gluconate, guys? Simply, it stabilizes the myocardium. Okay. How it stabilizes the myocardium? Again, a lot of basics are needed in this one. Simply, calcium go and it attaches to the receptors and it antagonizes the membrane action of hyperkalemia. It protects the cardiac conduction system. Okay, it doesn't change the level of potassium in the blood. It stabilizes the myocardium. The onset is within minutes and it lasts until 1 hour, half an hour to 1 hour. So that's why we keep on repeating dosages of calcium gluconate until and unless we had treated hyperkalemia. The next aim is to shift the potassium into the cell. What we can give? We can give them regular insulin. Now, guys, whenever we give insulin to the patient, what can happen? Hypoglycemia. So we give insulin with dextrose water. So dextrose water or glucose water is going to prevent hypoglycemia. And what will happen? The insulin is going to move more and more potassium inside the cell, right? So what we do basically, we give, you can say 10 to 20 units of insulin with 1 to 2 ampoules of dextrose 50 water or highly, you can say, glucose water. And we keep on checking their blood glucose level so that the patient should not go into hypoglycemia. And the action starts within 15 to 30 minutes but last for 1 to 2 hours. So we can repeat this thing every 4 to 6 hours. One of the things we can give them is sodium bicarbonate. That's CO3. Okay. So what it does, like it also drives the cells into the cell. How? If you remember, in exchange of hydrogen, when we give this thing, what will happen? There will be alkalosis. So more and more hydrogen ion will come out from the cell, and more potassium is going to go inside the cell. So this is most effective in metabolic acidosis. So see, you are killing something, two things with one bullet. So you are giving this thing to neutralize acidosis as well as potassium will move intracellularly. One of the things we can give is, if you know what is Ventolin, which is basically salbutamol, or which is basically beta 2 agonist. Okay, it comes by the name of Ventolin. So we give them nebulization of that thing, and remember, that thing do what? It stimulates sodium potassium ATPase, which will move more and more potassium inside. One of the side effects of this thing is, of course, tachycardia. Okay, so see, this one is to stabilize myocardium. These three things are to move the potassium. We are not excreting potassium, we are just playing potassium inside the body. What is outside the cell, we are throwing it inside. Now the last thing which you can do is to you can say enhance the removal of potassium from the body. Now you are doing the things in which you will throw the potassium outside the body. So if you can throw the potassium either via urine or either via GIT. Okay, so how you can throw the potassium by the way of urine? Give them furosemide, and this is the preferred way of throwing. So furosemide, when we'll give, it's a diuretic, it can cause hypotension, so you can give furosemide with IV fluids or normal saline. Okay. One of the way we can also do is we can give the patients fludrocortisone. Okay. What is this? It's a mineralocorticoid. Okay. And if the patient have, for example, aldosterone deficiency, it is going to meet with that. And what aldosterone will do, it is going to retain sodium and throw out potassium from the body. If you are using GIT way, then we can give the patients cation exchange resins. There are many. One is called as calcium resonium, and so one thing is called as sodium polystyrene sulfonate. What it do, by the way, uh, they have a lot of side effects, but it works by binding sodium in exchange of potassium. So it keep on binding sodium, and what will happen? The potassium is going to remove from the body. We can also give lactulose or sorbitol per oral. Okay, but uh, they have the side effects as well. One of the thing is like giving salicylate or sodium polystyrene sulfonate in enema form as well, but that's not important, like not so commonly used. But the ultimate way, or if the person is going into life-threatening hyperkalemia, which is not responsive to any type of therapy, go for dialysis, hemodialysis, right? So dialysis, guys, in life-threatening and unresponsive or and refractory, you can say, hyperkalemia. Okay, we choose dialysis. So that's the ultimate thing we can do. I hope you understand. The things are easy, not so hard. Okay, just a little concept of is needed, like how the potassium is regulated in the body. Thank you so much, guys, for listening.